Hello, I'm very glad to join you for this 50th anniversary gala of the Hastings Center. I'm very grateful to Millie's invitation, and I'm going to give a brief address about artificial intelligence and how it can have a big effect in healthcare, with lots of caveats, of course. Before I get into that, I just want to point out that 45 years ago, I was writing about the Hastings Center. So I've had great admiration for Hastings Center and its influence in ethics around the world. And this was a thesis I wrote when I was at University of Virginia in 1975 about prospects for genetic therapy in man. It took a little while for it to actually get real, but indeed it has. And along the way, the Hastings Center, along with every other critical ethical dilemma, has been a key influential force. So in medicine today, the short-term importance of artificial intelligence is to get us to a much better place with respect to accuracy and precision. These days, precision medicine is the buzzword, but it's no good if it isn't accurate also. And we are very short of that. So artificial neural networks were inputs of data with respect to particularly imaging in healthcare, but more over time will be speech and eventually text. Those inputs can act like neurons in our brain, and the outputs can make for training machines to come up with things that humans can't do or do nearly as well. So an example of that would be a chest x-ray where a radiologist misses a nodule which turns out to be cancerous. And this has been shown to be the case in many studies of images. This is just a chest x-ray example. Here's mammography, a similar thing where even expert mammographer radiologists will miss things. But by training with hundreds of thousands, if not millions of images as inputs, the neural networks can get so good at picking up things and making the diagnosis or the interpretation more accurate. The best way I can convey that is through the retina picture. This retina picture could be shown to international experts in the retina and ask them whether it's from a male or a female. And they would say 50% chance of being right, whereas a neural network can be trained with 97% accuracy. Yes, there are better ways to determine gender, but this just shows you how images can be discerned by algorithms, by neural networks, in ways that people, experts, can. So when a machine sees in the retina is a gateway of things we never realized that could be seen. So for example, tracking kidney disease, tracking diabetes, blood pressure, Alzheimer's disease, and when to intervene in someone with macular degeneration. These are things that we couldn't see as humans, as even experts, clinicians, but we can now start to see how this picture has immense information encoded that machines can pick up. As a cardiologist, throughout my career, I love to read cardiograms, but I never imagined you could tell the age of the patient, the gender of the patient, whether the patient is anemic and how severe, as well as the heart function, and also be able to make difficult diagnoses, all through AI. And the same is for pathologists on a slide, to be able to pick up the driver genomic mutations that are causing the cancer. This is pretty extraordinary that we couldn't imagine a slide would have so much information in it that would be missed by a person but picked up by a machine. So that just gives you a sense across every clinician type, every discipline of medicine, this will have a marked important impact. Here's a colonoscopy, and gastroenterologists have done some of the leading work in the field, where during the endoscopy, the gastroenterologist is picking up things through machine vision that otherwise would be missed, and in real time telling the gastroenterologist whether it could be cancerous or not, and being able to avoid biopsies or to do the biopsies that are actually indicated. So it's not just across all medical disciplines, it's also across the health span, from in vitro fertilization all the way to being able to predict the prognosis of patients who are in the hospital, and so many different things along the health span. So to summarize for clinicians, this quote is quite apropos. Machines will not replace physicians, but physicians using AI will soon replace those not using it. But it's not just about doctors. It's also about patients. So now, even a few years ago, the first deep learning algorithms were approved by the FDA for detecting heart rhythm abnormalities like atrial fibrillation. And now we're seeing many more, such as urinary tract infection, self-diagnosis with an AI kit, skin lesions, ear infections in children, all sorts of things where autonomy of patients, not doctor-less, but at least getting the initial diagnosis, then to be confirmed by a physician, and if need be, treatment be prescribed. Eventually, each person will have the ability to have a virtual medical coach with all their data from many different sources, whether it be their scans, their sensors, their electronic health records, the medical literature, all being processed and fed back to a person to coach them from either preventing an illness they were high risk to have, or even to have better management of a chronic condition. My favorite device, which now is getting very into AI, is the smartphone ultrasound, because this is quite remarkable. The images that one can obtain by plugging in a probe to the base of a smartphone. Here's the heart, everything you'd want to know about the heart within seconds. This transcends the era of lub-dub stethoscopes, because here we can actually see everything. And this is quite remarkable. Not just the heart function, the squeeze power, but also the thickness of the heart muscle, the valves, the size of the cavity, the chambers, and even tracking the blood flow of the heart. This is so extraordinary that I decided to use this on every part of my body. As you can see here, a medical selfie with smartphone ultrasound, all the way from the carotids, the sinuses, thyroid, the lung, the heart, liver, kidney, gallbladder, iliac artery, spleen, aorta, inferior vena cava, popliteal fossa, and my left foot, all within minutes. And why is this important? Because now, with AI, it can guide an individual who has no idea what they're doing in acquiring the image to say, move the probe up or down, or clockwise or counterclockwise, and it automatically can capture the image and label it and help interpret it. So this is a pretty remarkable advance that we're starting to see in AI going forward. And that would be the case for anyone in the world to be able to do AI of imaging of any part of the body except for the brain because of the skull. And this is already starting to take place in remote places in Africa and India. So that gets me to the point of this could reduce inequities, AI, but it also could worsen them, of course. And this is a very good Principal AI white paper that was put out by the Berkman Klein Center. And it touches on all the key things like privacy and fairness and security, accountability, all the things that we need to strive for, which we're not there yet with AI. And in fact, this is a really good paper in the New England Journal in June, which goes through 12 different algorithms that have embedded bias, racial bias, not because the algorithms are at fault, but because it's embedded in our real world. And we need to be very aware of this when going forward with AI in healthcare. So just to close a couple of thoughts, it's great that we can help improve accuracy over time. A lot more work needs to be done to validate all that. But what we need the most is not just accuracy. We need to restore the empathy in medicine. That is the human bond, the presence, the trust, this very precious relationship between a patient and doctor. And there is no algorithm for that. And Francis Peabody wrote a classic paper almost a century ago And it's 6 pages, and it's easily downloadable. And I just turned to the last part where he wrote, one of the essential qualities of the clinician is interest in humanity. For the secret of the care of the patient is in caring for the patient. And this is the most exciting future overarching direction for AI in healthcare. We want to give the gift of time that AI could provide by making the lives of clinicians much easier and more streamlined, but also giving patients more autonomy and control and engagement in their own healthcare. This would give the gift of time, and it's the segue to a far better medicine, the essential aspect of the human connection. Let me just acknowledge all the people, the great people I get to work with at Scripps Research and our funding sources, and I very much look forward to our discussion with Millie and your questions. Thanks very much.
Thank you very much for those terrific remarks, and not the least for going back to your dissertation to let us know that you were guided by the Hastings Center even back then at the start of your wonderful career. We all appreciated the shout out.
Oh, thanks.
Yeah, it was
45 years ago, Hastings was already having a powerful influence. Yeah.
It really feels good to know that. Thank you. It's exciting to see that the benefits of AI are already being realized in so many different contexts. But then, Eric, at the end, you ended with comments in which you made a connection. You made a claim, and I'd like you to spell it out a little bit more. You suggested that AI will not only give us earlier and more accurate diagnoses, but that it can also, I don't know how to put it, help repair modern medicine, so to speak, that you're hoping it can actually enhance physicians' capacities for empathy and in more humanistic medicine. And I wondered if you could connect the dots for us. Why is that likely to follow?
Well, it won't happen by accident. The latter, that is the deep medicine, the idea that we could restore the precious relationship. So, back when I was in medical school and my early training, there was a precious, intimate relationship between a doctor and a patient. And that was something that I think represented the essence of medicine. It's a human connection. The problem is that over time, all these decades since, there's been constant erosion of that, which has been accelerated in the electronic health record era with keyboards and not even looking at patients, but also the administrative takeover of American medicine, especially, whereby the squeeze on clinicians to see patients very quickly, and patients are getting shortchanged. They don't even have a time to express what's bothering them because they get interrupted within seconds. They don't get listened to. There's no trust and presence, and everything is just different than it used to be. So what we're talking about with AI is not just what you cited, which is we can really rev up accuracy. That is clear. But the more far-reaching objective is to the gift of time. That when we get together, a patient and a clinician, that we actually have the time to really listen, to be present, to express compassion and empathy, which the reason why we went into medicine, right? Mm-hmm. But we lost it, and that's why there's a global crisis and a burnout now. So I'm optimistic, but it will have to be done by activism, because otherwise American medicine especially is run by administrators who they have to answer to financial business criteria, whereas the people that are actually on the front lines have a different mission.
In my introduction to you earlier, I drew attention to the fact that you have been calling for activism, physician activism, and you've, basically called out the idea that you don't think we should be thinking about trade guilds that are protecting physicians, but rather physicians mobilizing on behalf of the inspirational reasons that they went into medicine and on behalf of their patients. So let's assume that progress is made in that direction. What should we be advocating for? Again, it's kind of the question of what should be put in place if AI is going to help realize a more humanistic medicine? What are the things you'd like people to call for?
Well, I think if physicians stand up and along with them, the whole healthcare team, nurses and, all the different professionals and say, we want the gift of time. We're not going to see patients in 7 minutes. So that reminds me of a really interesting story that occurred in Geisinger Health System. And what was interesting there is they had um, a rule for a stretch that you had to spend 40 minutes with a patient, and you couldn't leave the room, neither the patient nor the doctor, unless you had gone 40 minutes. And what's really fascinating about this is it was hard for the doctors because they weren't used to spending so much time with patients. Ultimately, they loved it, and the patients loved it. And so the gift of time here is what I think is central. So what's going to happen if we do this right, really, is a lot of visits can be done, routine visits that are not essential could be done remotely and rapidly. And also a lot more autonomy to patients because they can do a lot of the gathering of data, generating data and algorithms themselves over time. But the critical meetings that take place shouldn't be rushed. They should go to their natural extent of what it takes to listen and to respond and to have a true meaningful bond and interaction. So that's the hope, is if we work on that and we fight for that and we don't let these people that are the bean counters prevail, and I think we can get there. But otherwise what it'll turn out, Millie, is it'll go the opposite direction. Now that you have all this AI power, see more patients.
Yeah.
Read more scans, read more slides. You can just imagine, do more procedures. Like, those colonoscopy, you can go faster now because you have machine vision. So I want you to do twice as many now. You can make more money. So we have to buck that because it could be abused just as much as it can be exploited for, positive, good things.
We can call it activism, and we could also call it professionalism, good old-fashioned professionalism, to set limits on authority over one's own practice.
Yes, I think that's a great way to put it, like that.
Eric, you've written a lot about, how it could go both ways and that there are a lot of ethical issues that we do need to address. And the first one I'd like to put on the table is the issue of fairness. And I'd love for you to address fairness at two levels: organizationally and at the individual level. And what I mean by that is, organizationally, we already have a two-tiered system. I think you'd agree. There are wealthy hospitals and sophisticated academic medical centers that are developing or purchasing AI tools right now. You've shown us some of them. But also poor health systems, or health systems serving the poor, especially in rural areas of the country, that are not as likely to be able to get these tools. So could transformative AI further bifurcate our health system? And then at the individual level, might inequality be exacerbated because the patient-generated data that you're talking about is mainly going to come through smart apps that, like people's watches or other apps that they have in their home, and those tend to really be used by the wealthy. So,
do you see this as an issue, and what recommendations would you have for how we handle this?
Right. Well, I think this is central, that we could make things not just very unfair, worsen inequities, all sorts of adverse effects of AI. But we're not using the things we have in the right way. So, for example, with Moore's Law over the last 50 plus years, the cost of smartphones, apps, software, is trivial relative to one visit to an emergency room. You can't go to an emergency room with a charge less than $1,000. Where you just think about one night in the hospital, it charges over $5,000 in the US. So if we just gave people smartphones who couldn't afford them, and apps and data plans for years, we could afford years, we could give them a lot more autonomy, prevent having to go to the hospital. And we've already seen now around the world how you could utilize these algorithms and AI tools in the hinterlands of Africa and India and other places. So it's a matter of getting the hardware and the software to the people who need it. And we're not smart about this. This is cheap stuff. I mean, you can get a smartphone that doesn't have all the bells and whistles maybe that many people have, but it's highly functional for $50. And your data analysis plans, we should be working on companies to give people who can't afford analysis plans, just like people that can't get prescriptions, they can't afford the prescriptions. We should have plans for people who can't afford data analysis. Data plans. So, we're not being creative about this, and we need to be. Now, as far as the fairness, we have a problem of systemic racism. And that systemic racism gets into algorithms and AI, but it isn't the AI's fault. It's because it's embedded. So we can't blame AI for that, really. We can just blame, hey, we got a problem. We need to fix this. And I hope that we will address that, because that is, of utmost importance, and it's overdue. So, there are lots of things we could do that we're not doing right now to get us on the right track.
Thank you for raising the bias issue. I think, people hear that a lot. It's a theme in a lot of the ethics literature that people have been talking about.
I saw a really interesting study where people wanted to identify patients who were going home, they were being discharged, and wanted to find the people who could most benefit from some sort of home care plan. But they chose the wrong metrics. They decided that they were going to identify people who were high cost. And they missed a large proportion of the African Americans who were not high cost, but who were equally sick or sicker and would have benefited from the home care, but they weren't. Was the wrong metric to use, because they were already underutilizing services, so they came up as less costly, not because they were less sick.
So
that's the most famous recent example. That's the paper in Science by Ziad Obermeyer, which is just, that was used by Optum in millions of people, tens of millions of people. And it was an embedded issue of inequities because of the assumptions made going into it. So we have to be so conscious and aware of this before implementing any AI. And the other thing just to mention is, when you have an AI that's functional and validated, and you've made sure that it doesn't have, embedded unfairness and inequities, then you also have to keep it under continuous surveillance, because it could be subject to adversarial attacks. So we're still very early in AI in healthcare. We have a lot to learn, but we have to keep our guard up for sure.
We talked about fairness and trying to guard against greater inequality.
A third question I have for you has to do with the level of evidence that we should require of AI tools before we let them out the door, so to speak. Several high-profile health systems are making very large investments in AI, including major purchases from private companies like IBM and Verily. But it's my understanding that we often have very little evidence on the efficacy of these tools, or on their safety, or whether they are biased or not. They're rarely tested in randomized controlled trials, or even evaluated by less stringent measures. So should they be released before they've been studied? We have the FDA for medicines. Do we need something stronger for AI?
Well, I think so. I think you're really got your finger on an important pulse here, right, with this, because what we are relying on to get these commercially approved and used are FDA authorizations. They're not approvals, they're 510K clearances. They are retrospective data sets usually, typically. Sometimes they're prospective, but the main point is they're not in the public domain. They don't get published. Mm-hmm. So you basically are relying on, a relatively easy path at FDA to get clearance. It's not even a formal approval. And then they're now marketed to health systems. And the people that are using them don't even know the data, because it's never been published. So not only do we need, rigorous prospective studies to validate in the real world, but we also want to see all this stuff published transparent, so that when you're buying something that you're actually getting something that, it has proven validation that it's likely to work very well, because you're also getting at this other issue. This could be used in a lot of people, any algorithm whether it's in radiology, pathology, you name it, it could be used at scale really quickly. And if it's off for some reason, like for example, the patient population was tested in, or some of the assumptions that went into the models, or various steps along the way, it could hurt people at scale too. So this is why I'm very unhappy with the way things are right now, because we're not getting the ultimate validation we need before we put trust in algorithms. Like I already mentioned, they need to be under surveillance even after they're used in any health system. But moreover, we want to see any of these get peer-reviewed publication and to be done really well. And those are few and far between. I mean, I can count on two hands the papers that I think fulfill that ideal type of validation. So we have a ways to go.
Well, that is a perfect place to stop. It's always a pleasure to talk with you, Eric. Really, it's just a thrill. And I want to thank you so much for helping us celebrate our last 50 years and launch us for our next 50. Thank you so much.